So this is the initial exposure of say an allergen. It comes into the airway here. This is a mucosal epithelial cell lining. Now some allergen fall upon these dendritic cells or antigen presenting cells, which join them with class 2 MHC, and these appear on surface. Here type 2 helper T cells, which are remarkably present more in asthmatics, get attached to the MHC by their CD4 receptors, and this activates them to release cytokines and TNF alpha. TNF alpha stimulates epithelial cells to secrete chemokines, which attract T cells and eosinophils to them, and these cytokines, also interleukins, activate B cells into plasma cells, which produce a lot of IgE or immunoglobulin E. These IgE bind to Fc receptor on mast cells and activate them. Also, some cytokines from T cells and mast cells induce recruitment of eosinophils, neutrophils, and basophils from capillary into submucosa. Eosinophils are then attracted to lumen by eotaxin, a chemokine secreted from epithelial cells, and thus all these things makes the airway hyperresponsive. So this is our hyperresponsive airway, and there is this repeat exposure of triggers which causes these bombs to blast and release histamine and leukotrienes. Now all these chemicals, the histamine, leukotriene, chemokine, cytokine, TNF alpha, and others, are called inflammatory mediators, and they in association produces these effects. First, they cause increased number of goblet cells and hyperplasia of mucous glands. Second, they cause bronchoconstriction, especially by leukotrienes, histamine, and acetylcholine, which is the effect of these sensory nerves being activated by these mediators. Third, plasma exudation from capillaries, which causes airway edema. And fourth, in untreated cases, these mediators cause subepithelial fibrosis, which makes the narrowing irreversible. Now, some important points. First, at night, our adrenaline and cortisol level falls, which increases mediators, which increases bronchial tone. This is normal but becomes exaggerated in asthmatics. Second, in exercise, as we need more and more air, we breathe through mouth. This brings in cold air, which vasodilates capillaries. This is normal, but in asthmatics, plasma exudation occurs, causing airway edema, hence narrowing. Third, in aspirin, it increases leukotrienes and therefore causes problem in asthmatics. So this is the same figure as in our first video. This is our inflammation, bronchoconstriction, and mucus secretion. And you know that there are sensory nerves which are stimulated by those criminal chemicals, and these nerves, apart from that cholinergic reflex, also make the brain perceive a feeling of chest tightness. And the input from these nerves also produce a cough reflex to clear out the mucus. So there is cough with sputum. Also, when the air passes over this mucus, the air fluid interaction produces a low pitched sound called rhonchi. which sounds like this. Now, when the person exhales out, some air gets trapped behind the obstruction because the passive relaxation of diaphragm and elastic recoil of lung are unable to overcome the added resistance, and this causes hyperinflation or increase in residual volume, which results in decrease in tidal ventilation, and this is perceived as shortness of breath. So, with the air not able to fully go out, there is this difficulty in breathing out. Now, the brain responds by making internal intercostal muscle and abdominal muscles to contract, which increases the intrathoracic pressure and forcing the air to expel out. This reduces some trapped air. The force also increases the velocity of air, which vibrates the wall of the airway to produce a high-pitched sound called wheeze. It sounds like this. If the airflow obstruction is not corrected, the air remains trapped, and to inhale the same amount of air at higher lung volumes causes difficulty in breathing in, and the brain now contracts inspiratory muscles, the external intercostal and the neck muscles to inhale the same amount of air as the person was inhaling normally before the attack. Just to show you here that if you give a bronchodilator, the narrowing decreases, the trapped air expels out, lung volume comes back to normal, and the tidal ventilation is restored to normal baseline levels. But if untreated, eventually after some minutes the muscles exhaust and fatigue and sweating occurs. Now, for those of you who wondered why I have shown obstruction in this airway, it's because there is a concept. Now, you know that this is trachea, main bronchi, lobar bronchi, segmental bronchi, large bronchioles, small bronchioles, alveolar duct, alveolar sac, and alveoli. Now, mucus production occurs where there are goblet cells or mucus glands. So, they are here, here, and here. And bronchoconstriction occurs where there is circular muscle, and it is here, here, and here. But in bronchi there is cartilage too, which prevents the narrowing of lumen. And in alveolar duct and alveoli there is only epithelium. So again, this is the part where mucus production occurs, and this is the part where bronchoconstriction occurs. So now you know what happens, how it all happens, and where it happens in an asthmatic lung.